Hi, I'm Anthony Gosh, a consultant spinal neurosurgeon and the founder of the Spine MDT. In this video, I'm going to talk about the problem with MRI scanners or clinical investigations in general in the context of chronic lower lumbar back pain. This is quite a short video, but please watch it. And if you hang around to the end, I'm going to explain some interesting studies in how a scan should be interpreted in a way that can help you understand it, but interestingly help you improve your back pain. Chronic back pain can be debilitating, and in my practice I often see patients who have had a scan. The scan results weren't properly explained to them. They've just come to me with a report with extreme anxiety about the findings of the report, or they have been to numerous practitioners who haven't really got to the bottom of the pain, haven't really found a solution, and often feel that an MRI scan is what they need to get to the bottom of the problem. But here's the thing, in any area of medicine, the diagnosis from a good clinician, when they're assessing you, the diagnosis should come from the history, from a conversation they've had with you, asking you the right questions, allowing you to speak, and really getting to understand what the problem is. And then from the clinical examination. Most of it is actually from the history. By the time your consultant or clinician has finished speaking with you, they've already got a good idea, or should have a good idea, of what's going on. And then the clinical examination will actually get you to stand up, have a feel of your back, get you to do certain maneuvers. From there, these things help confirm it or be a bit more assertive of the cause of the problem, and then any tests that are requested are just there to confirm that. It shouldn't be the other way around, because MRI scans are very sensitive and pick up all sorts of things that are not always relevant. So a good clinician has to be able to put all of that into context. The problem with chronic lower back pain is that there often isn't a well-defined pathological cause of the pain. There might be certain drivers of the pain, certain things we do that aggravate the pain that we can identify, but it's rare that there's actually a really good going underlying pathological cause that you can clearly say on the scan, this is the cause of your back pain and this is the intervention we're going to do that's going to suddenly make it go away. So to be clear, I'm talking about pain in the lower back that's not necessarily radiating down the legs, doesn't have any nerve compression or sciatica pain shooting down the legs. This is pain that's usually focused in the lower back. So let's try and understand the mechanisms of pain in general, back pain, and then the sequence of events. So initially there's the initial cause of the pain. So that could be a tear in the muscle, or for example a tear in the disc. And we call that nociceptive pain. That's the pain you get from that initial injury to the back, however trivial it may be. And that pain usually lasts for about a couple of weeks. In the background of that, and then persisting for another few weeks, up to 12 weeks or so, you then have the secondary inflammatory pain, so inflammation and swelling in that area, which causes a lot of the pain. It's usually not as bad as the pain in the initial 2 weeks, but it's there in the background, and things you do can aggravate it. And then in a lot of patients, that then settles down. And then what we're left with in a subset of patients is what we call nociplastic pain or chronic regional pain. By definition, that's at this point where you don't find an underlying pathological cause. And that's because at this stage, whenever patients have been imaged, either with a scan or anything, you're not seeing the inflammation or the muscle tear or the disc tear has possibly healed up. So you're not seeing the actual cause of the pain. And there are certain drivers of that ongoing pain. If we think of pain as total as a great big puzzle, in the beginning, the first few weeks, the pathology, or either tearing the muscle, the disc, or whatever the cause is, makes up most of the pieces of the puzzle. But then after that 3-month period, that original pathology, that original cause, is probably not non-existent or only one piece of a greater puzzle. And then abnormal beliefs that we've been given about posture, things to avoid, guarding, behaviors that we adopt, and then fear, stress, anxiety. These are really potent drivers of pain. There's been a lot of myths, and I've debunked a lot of these in other videos I've done. If you check out my video with Professor Peter O'Sullivan, he's done a lot of research about common myths that we believe about posture, how you have to sit upright, and that's apparently the cause of your back pain because you haven't been sitting properly is complete nonsense, and no study has ever correlated posture with back pain. Also, patients are taught, and it's down to us, the medical profession, about having a poor core strength. The core being this magical muscle that apparently supports your spine. Well, it's actually part of a bigger system of muscles, and it kind of gets overemphasized. It has its place, and Stuart McGill, another person I interviewed, who has a really good understanding of the biomechanics of back pain, talks about the different mechanisms, and he came up with the McGill Big Three, certain exercises. That all has its place if you've clearly identified very specific causes where those exercises can help. But often these beliefs and adaptations in our posture, certain things we do and behaviors we make, have been proven to aggravate and make back pain worse. And then if you have low mood, fear and anxiety, these are again potent amplifiers of pain. Pain is perceived in the brain regardless of the cause in the body. It's perceived up in the brain, and then enhanced in the amygdala, the emotional center, and all these factors in your amygdala can really amplify the pain and make it worse. So unfortunately, it leads to MRI scans quite often. And one of the problems I've seen with MRI scans is patients are often given the report, especially in the UK, because of access to information. Patients are given the report, read it, or it's been explained to them by a clinician or someone who doesn't fully appreciate how to interpret the actual images for themselves. And that can aggravate or amplify all of these things we just spoke about. This is a really interesting study that looked at features of MRI scans in populations of patients who do not have back pain, who've not suffered with back pain. This is in the American Journal of Neuroradiology. And this is really interesting findings. These are common words. These words: disc degeneration, signal loss, height loss, disc bulge, protrusion, annular fissure. These are common buzzwords we see on MRI scans, which can aggravate the pain, and it's been proven to do so. And look how common these findings are in patients who have never experienced back pain, and these are the different age groups. Above the age of 40, 68% of people who have never experienced back pain actually have disc degeneration. So that's how common a finding it is, and therefore we've been falsely telling patients, this is the cause of your back pain, this must be the problem, you've got degenerative discs, this is irreversible. And then patients are left thinking, well, that's the end, that's it for life. And that's been proven, that cycle has been proven to exacerbate back pain. And as we get older, 50, 60, look how common these findings are. Now, under the age of 50, or in this sort of age group, under the age of 50, yes, in a small subset of patients, these findings here, annular fissure, spondylolisthesis, are slightly more commonly seen in patients with pain, so can possibly be the cause of the initial pain. And these are important things to be assessed by a surgeon, be absolutely clear if it's still the ongoing cause, but often it isn't. So this leads us to another study that was carried out, a really interesting paper looking at the catastrophization effects of an MRI scan report on patients, and what it does. And it showed some really interesting findings. They took groups of patients who have lower lumbar back pain. One group of patients was simply given the report or read the findings of the report, where these buzzwords here were commonly used. And in the other group of patients with back pain, the report was explained to them by a clinician in simple terms, and often the findings were explained to them to say that, look, these are not that bad. And then there was a second phase of the trial where the report was rewritten in using that sort of language, not using the frightening terminology. And amazingly, the group that had it explained to them, who basically got the same findings as the other group. The group that had it explained to them had far better outcomes, far better improvement in their symptoms, whilst they were both undergoing physiotherapy in the background. So that proves to you, that actually proves how catastrophic reading an MRI report without having it explained to you can actually be. And these are the common buzzwords that we see, spondylosis, spondyloarthritis, on the background of what is generally a normal scan. These findings are very, very common, and I often tell patients, this is how I've summarized those findings to patients. These are age-appropriate changes that should be considered as normal, and I often put a line like that in the clinic letter to summarize that. So in my practice, I only scan patients when I'm suspecting from the clinical history nerve compression. The other scenario is if a patient has a lot of fear that's already been imposed on them from what they've read online and so forth, and I'm struggling to reassure them. I often find I use the MRI scan as a tool of education, just as a tool to reassure them that actually things are fine. It's not absolutely necessary, but in some patients, I find it can help just purely to explain to them the findings, as I showed before, that these are all normal findings. Your back is quite healthy, and interestingly, those patients go on to do quite well. And this is partly why I started the Spine MDT, where I kind of bring together all the different types of professionals that deal with back pain. So a surgeon, myself, osteopaths, chiropractors, physiotherapists, pain specialists, so that there's a channel of communication between all the different people that are treating the same patient, and that can often help avoid all of this miscommunication and misconception. I hope you found this video helpful. If so, please click like and subscribe to the channel. It really helps people suffering with back pain or spine disease find information that I try and post on the channel on a weekly basis. For more information, you can visit us at spinemdt.com and try our online spine assessment tool. There's also a link below to find out more about our new bespoke clinic that will soon be running in Harley Street.